Assalamu alaikum dear students. And the previous lecture we end up the lecture on the three tests of the glenohumeral joint, but some points are being added to the inspection portion of the clinical examination of the shoulder. So after these discussion of these points, we will then proceed to our topic, which is the glenohumeral joint clinical examination. So this slide has been added to the previous lecture. So we are going to discuss that, and after that we will then proceed to our next new topic. During the inspection, the patient should undress to enable the area to be inspected in a good light, and a general inspection will determine any bony deformity. Look at the cervical spine position and take an overall view of the spinal curvature, specifically the kyphosis of the thoracic region and the cervical lordosis. And because these two curvatures, they have some influence on the shoulder biomechanics. The general posture of the patient can be important, and any observation of the asymmetry are recorded if they are relevant to the presenting condition. It has been postulated that abnormal cervical and thoracic posture, specifically the thoracic kyphosis, if it is being increased excessively, then the condition that will alter the resting position of the scapula and may be related to the shoulder pain, which is because of the overuse. Similarly, the attitude of the shoulder should be noted. Is one higher than the other or excessively medially rotated? So the shoulder symmetry should be checked. Either the shoulders both are symmetrical or they are asymmetrical. In a frozen shoulder, one shoulder may be held higher than the other due to the pain, along with the elevation and retraction of the scapula. The position of that scapula should be noted, specifically in such patient with frozen shoulder, as they are more or less symmetrical, lying approximately 3 fingers from the midline, or they excessively retracted or the protected. There may be evidence of the winging of the scapula, but this is usually more obvious on movement, specifically and during the movement elevation of the shoulder joint and the adduction, especially on the flexion. There may be or some rotation in the shoulder joint. There may be the visualization of the winging of the scapula. It is more obvious when there is internal rotation of the shoulder joint. Similarly, in the inspection, the lumps, scars, bony prominences, and bruising should be observed. A prominent bump at the end of the clavicle may signify an old fracture or dislocation of the acromioclavicular joint. Similarly, the color changes and the swelling that should be noted. And these are unusual findings at the shoulder unless associated with some direct trauma. The muscle wasting is suspected if the spine of the scapula is prominent due to the neuritis or the rupture of some components of the rotator cuff muscles. In chronic rotator cuff tendinopathy or their degenerative tears, the wasting of the both supraspinatus and the infraspinatus that may be obvious. The Popeye deformity of the rupture of the long head of the bicep is usually obvious, but the patient does not particularly complain of pain. It remains asymptomatic. There is no such complaint of the pain from the patient. In case of deltoid atrophy, the squaring of the shoulder occurs as deltoid is no longer rounded over the humeral head and may be indication of the anterior dislocation. So that was all about the inspection, some extra points which were not discussed previously. And now we will just go and proceed to our next topic. We have ended our previous lecture. So these are the three tests which are used for the glenohumeral joint. And among these, we will discuss some passive movement initially, and then we will discuss the resisted movements. In the passive scapulohumeral abduction, the lower angle of the scapula is immobilized by the examiner by the thumb and index. With the other hand, the examiner takes the patient arm just above the elbow and lifts it up until the scapula starts to move. Dear students, it is very important for the patient not to assess this movement actively, because then the scapula immediately start to rotate, so making the movement a compound one involving the several joints, the humerus and the scapula, that take place. If the movement is impaired, the glenohumeral or the subacromial joint is at fault. This is the position of the therapist. The therapist will just immobilize the scapula while putting the index finger on the vertebral border of the scapula and the thumb on the lateral border of the scapula, and the inferior angle of the scapula will be at the that junction of that wave, and the function and the significance of this position in this hand is just to immobilize the scapula. Then the patient will just hold that elbow above the elbow and will try to lift it up and will check that abduction. But there should be noted that there should be no assistance from the patient. This would be totally passive scapulohumeral abduction. There should be no passive assisted. Otherwise, if the patient will assess this movement, then the scapula will start a rotation immediately with the abduction. So it will make the movement a compound one involving the several joints. Secondly, the next is the passive lateral rotation. In the passive lateral rotation, we will first discuss that what the examiner will do, and then we will discuss the another component as well. In the passive lateral position, the examiner takes the patient arm above the wrist and flexes the elbow to a right angle and pulls the arm with gentle pressure into the full lateral rotation. We can say that the external rotation. Meanwhile, avoiding extension by holding the patient's elbow against the side of the abdomen. Similarly, the examiner will also immobilize the trunk of the patient by bringing the other hand around the patient's contralateral shoulder, like that. He is being immobilized the trunk by this hand. He is checking the passive lateral rotation of this shoulder, but his other hand is on the contralateral shoulder just to immobilize the trunk. One hand is just above the wrist and flexes the elbow at a right angle and then pulls the arm into gentle pressure to the external rotation. At the same time, to the abdomen, the examiner will avoid the extension of the elbow patient. So, similarly, this movement comes to stop by stretching the interior portion of the capsule. Therefore, the end field is elastic. The normal range is about 90 degrees. Since individual differences exist, so both sides should always be compared. Beside the interior portion of the joint capsule, other structures such as the subcoracoid bursa, the acromioclavicular joint, and the subscapular tendons, they are tested as well. The limitation of the movement is mainly found if something is wrong with the scapulohumeral joint itself, and this even a harder end field is usually present. If a simple tendinitis of the subscapularis is present, that will not cause any limitation to the movement, but this disorder, this tendinosis of the subscapularis, that may render it very painful. The next is the passive medial rotation, the third passive test which of the glenohumeral joint. During the passive medial rotation, with one hand just still above the patient's wrist as is in the previous maneuver, and flexing the patient elbow into the 90 degree, the arm is brought into full medial rotation, or we can say that the internal rotation without extension. As we have discussed previously, that why the extension is necessary to avoid, because it will bias the moment, it will create error moments that change the results. The examiner's other hand is placed dorsally between the scapula, that is, one hand is just above the scapula, the wrist, and the patient's arm is being bring into the internal rotation, while his other hand is at the middle between the two scapula. And through the body, through the abdomen, this examiner will try to avoid the extension of this elbow joint, the shoulder joint, and hence there will be no such posterior movement of this elbow, and he will just check this internal rotation of the shoulder. Occasionally, a painful arc can be present on the medial rotation. This has the same diagnostic value as a painful arc on elevation, and bears the practical consequences that in order to test for the real limitation of the movement, the examiner must persist to get beyond the painful arc. This movement, as we discussed in the previous as well, that the shoulder, there should be some differences between the two sides, but this movement should be compared on the both sides. Now some resisted movements at the glenohumeral joint. The resisted adduction, the patient is asked to pull the right arm towards the body as hard as possible, like that, and the examiner put one hand around the elbow and the other at the patient ipsilateral side. So this side will be placed on the ipsilateral pelvis area, just the hip joint top, just to prevent any movement towards the examiner, while the other hands of the examiner, that will be put around the elbow. So he will, the patient will bring her or his hand towards the body, and the therapist will just by putting this hand over the elbow will resist this movement. At the same time, he will just put pressure on that area to avoid any movement towards at the hip joint towards the examiner. The second, the resisted movement, which should be checked during the clinical examination of the glenohumeral joint, this is the resisted abduction. In resisted abduction, the test is performed with the arm hanging down a few degrees of the abduction being permitted, like that, and the examiner asks the patient to push his or her arm to the side, meanwhile applying counter pressure at the elbow. Now the patient will abduct his or her hand away from the body. He or she will move the shoulder joint, the complete arm, into away from the body, and the therapist, by putting pressure on the elbow, so the examiner, the therapist, will resist this movement of abduction. At the same time, one hand of the therapist, the examiner, will be on the contralateral pelvis area, or you can say that hip joint top, just to prevent any movement at the away from the therapist at this side. Because when the patient is trying to counter the force of the therapist, so there may be some pelvis shifting to the opposite side, to the contralateral side. To prevent that pelvis shifting, the therapist will put one hand on the contralateral side. So this was the resisted abduction. So the examiner's other hand stabilizes the patient on the contralateral side. And so this is the difference between the resisted abduction and the resisted adduction. During the resisted adduction, to prevent the pelvis shifting, the therapist's hand was on the ipsilateral side, while during checking the resisted abduction, testing the resisted abduction, the examiner's hand, they would stabilize the patient on the contralateral side. The next is the resisted lateral rotation. The patient is asked to bend the elbow to a right angle and to push the forearm away from the body, like that. The elbow joint is being flexed to right angle, and the patient will try to move it away from the body. To avoid any movement of the trunk, the other hand is put on the patient's contralateral shoulder. So, while the therapist was checking the resisted abduction and adduction, this stabilizing hand was either on the ipsilateral side and the adduction, while in the abduction, resisted abduction, this stabilizing hand was on the contralateral pelvis area to prevent that pelvis movement shifting on either side. But during the resisted lateral rotation, the stabilizing arm, that will be on the contralateral shoulder, and just because when the patient is going to externally rotate or laterally rotate the shoulder joint, there should be no movement at the other side. So at that hand on the contralateral side on the shoulder, that is just to prevent and just to avoid any movement of the trunk. So when the patient is going to laterally rotate the shoulder joint, she will move the forearm away from the body. At the same time, the therapist will apply some counter pressure just above the wrist to prevent and to give resistance to that movement. Care must be taken to keep two details right. First, the patient should keep the elbow against the body so that there is no element of abduction. The elbow of the patient should be kept just beside and touch with the abdomen of the patient in order to have no abduction of the elbow joint. Similarly, therapist will put the little finger under the wrist. And what is the significance of this, putting that little finger under the wrist, just to prevent any extension of the elbow joint? So it means that the test will be, the resistance will be given when the elbow is 0 degree of abduction and at 90 degree flexion. So these two points that should be noted, and care should be taken for these. There should be no extension of the elbow joint, as well as there should be no abduction at the elbow joint. So first, the patient should keep the elbow against the body, against that side of the abdomen, so that there is no element of the abduction at the elbow joint, as well as secondly, extension of the elbow during lateral rotation is avoided. and the therapist that will help by avoiding the extension at the elbow joint by putting the little finger. We can see it in this picture that the little finger that is underneath the patient wrist. So the extension at the elbow is being avoided. And the next we will just discuss the resisted medial rotation. In the medial rotation, this resisted medial rotation is tested in the same position as we discussed in the position of the resisted external rotation. But the patient arm is held at the inner part of the wrist and the forearm is pulled towards the body. Like that, the patient in the previous picture, the patient wrist was held by the therapist from the outside, just to prevent that movement in the direction of the therapist elbow. But in this resisted medial rotation, the patient will move the forearm towards her body against in the direction of that elbow of the therapist. So that's why the fingers of the therapist, they will wrap around the shoulder's wrist from the inside. So and the 2 points which we discussed in the previous slide, there again it should be taken into detail that there should be no extension as well as no abduction of the elbow joint. And similar position is just like the resisted lateral rotation, the stabilizing hand that would be on the contralateral shoulder to prevent any trunk movement. So the patient will move the forearm towards her body while maintaining the 90 degree of the flexion and 0 degree of abduction at the elbow joint and in the shoulder joint. So there should be no distance between the elbow joint and the body. There should be 0 abduction at the shoulder joint. The therapist will apply equal counter pressure to that internal rotation of the patient. The next is the resisted elbow flexion, with the elbow still bent at the right angle as while checking the previous resisted lateral rotation, medial rotation. The forearm is supinated and the forearm is pulled up. The counter pressure is applied to the distal part of the forearm just above the wrist. So the hand is still, the shoulder is still at that position, the elbow is still at the 90 degree flexion. The difference between this maneuver and the previous is the hand, the stabilizing hand, which is in the previous, while we were checking the resisted medial rotation and internal rotation, the therapist's hand was on the contralateral shoulder. But during the resisted elbow flexion as well as the resisted elbow extension, the therapist stabilizing hand would be on the ipsilateral shoulder. So during this, there would be a 90 degree flexion, and the patient will try to move again the force of the therapist to move the forearm toward the shoulder. So she will try to flex that elbow while the therapist will apply counter pressure and will try to prevent any movement, any flexion at the further flexion than 90 at the elbow joint. The counter pressure is applied to the distal part of the forearm just above the wrist. The other hand is placed on the patient ipsilateral shoulder. Similarly, in the resisted elbow extension, the same position would be as it was for the resisted elbow flexion. The patient will attempt to extend the elbow to be able to hold the patient's elbow at 90 degree of flexion. The arm is in almost vertical position underneath the patient's wrist. So it means that the the therapist will be on the iliac crest or in the top of the thigh. So, the therapist arm should be just underneath the wrist and almost vertical to that wrist of the patient. The other hand rests on the patient ipsilateral shoulder like the resisted elbow flexion, and unlike the resisted elbow external and internal rotation. In the palpation section, it should be noted that palpation that should be always done after the clinical examination. Um, the general palpation for the heat and swelling is done after the functional examination. And these heat and swelling two symptoms they may be present in condition like the bacterial arthritis in the primary and secondary tumors of the humeral head, the glider and the acromion, as well as these may be present, these heat and swelling may be present in the acute and the chronic subdeltoid bursitis. Palpation for the pain is only performed when the basic examination proves that the lesion lies within the reach of a finger. As already indicated, it is always followed the clinical examination and never precede it. Comparison between the two sides is essential, and we will just compare the two sides in each and every test, as we previously discussed the different tests in the passive movements testing and the resistive movement testing. There should be comparison between the two sides. Palpation for the tenderness is mainly done in condition like the acute and the chronic subdeltoid bursitis, or tenderness palpation for tenderness may also be done when there is some sprain of the superior ligament of the acromioclavicular joint, because in these conditions there may be some tenderness. Tenderness means there will be no such pain. The patient will have no complaint of pain, but when there is the therapist will touch that specific area where the problem is, then the patient will feel the pain, and this condition when the patient feels the pain on the touch is known as the tenderness. So tenderness may be present in the bursitis when there is some sprain of the ligament. Accessory test sometimes the diagnosis is still not clear after the basic examination, after that clinical examination, as well as at other time the exact structure at fault has been identified by this stage of the examination, but the precise localization of the lesion within that particular structure remain uncertain. In these both cases, when the diagnosis is still not clear, or when the precise localization of the lesion within the particular structure remain uncertain, we need the one or more accessory tests. That these tests are required just to answer these and just to solve these problems or questions. So this is the summary of some accessory tests of the shoulders. These are not all the tests which should be conducted during the shoulder. These are some of the examples of those special tests, but these tests are not going to be discussed here, as we will discuss these accessory tests, the special test of the shoulder, along with their respective disorder or respective injury. So the examples of some accessory tests of the shoulder are the passive horizontal adduction, passive horizontal lateral rotation, apprehension test for the anterior instability, apprehension test for the posterior instability, load and shift maneuver, the sulcus sign, the Yergesen test, resisted horizontal adduction, resisted horizontal extension, resisted horizontal abduction with arm forwards, resisted flexion, resisted extension, pressure against the wall, scapular induction against the resistor. So these were some of the accessory tests which will be used during the specific condition, specific disorders. Uh, Technical investigation. All the technical investigation of the shoulders have in common the fact that they are performed to search for the anatomical changes. This is in contrast with the objective of a clinical examination, which aims to detect the functional deficiency of man. Anatomical changes they are very common in the shoulder region, and usually they remain asymptomatic, and they are not causing any functional disturbance, um, and their frequency increase with age. Sometimes one should always interpret the technical diagnosis with care and even reluctance, for it is perfectly possible that the lesion seen on imaging is in fact asymptomatic. In fact, it is without any symptoms, though it is seen on the imaging, but still there is no such complaint from that visualizing image. And another lesion that is not shown and that is being not identified or not possible to identify at that modality, that imaging, and that but still that will be the root of this disability. So it means that if there are two conditions present, the one which is seen on the imaging will be asymptomatic, and the other which is not visible on the image will be the exact root, will be the exact cause of the disability, will be the exact cause of the symptoms, will be the exact cause of the complaint of the patient. For example, a common mistake in the combination of a symptomatic glenohumeral arthritis that remain undiagnosed with the sonography. Sonography means the phenomena of the imaging of through ultrasound. Uh, the image, the pictures which is being received after the ultrasound, that is known as the sonogram, and this phenomenon is known as the sonography. There are two types of ultrasound, you all should know about that. One is known as the therapeutic ultrasound, the other is the diagnostic ultrasound. The diagnostic, we are talking here, that is the diagnostic ultrasound. The therapeutic ultrasound that is used to provide to provide two benefits, the thermal benefits and the non-thermal benefits, in which there is a current which is connected to a crystal at the end of the probe, and that probe that because of the current in it vibrate and just send some sound waves inside the tissue of the body, which will and that will provide some heat. On the other hand, this diagnostic ultrasound that is being connected with a screen, with a monitor, here there are images seen of the inside of the body. So during that sonography, during that diagnostic ultrasound, the glenohumeral arthritis, that will be the cause of the symptoms of the patient, but still this symptomatic glenohumeral arthritis that will remain undiagnosed with that ultrasound image, and that ultrasound image on the other hand, the rotator cuff tear, which is normally asymptomatic, and most of the people, they have some partial thickness rotator cuff tear but without any symptoms. So this asymptomatic rotator cuff, they will be easily detected with the sonography, but the other condition, the glenohumeral arthritis, which is causing symptoms, which is causing the some complaint and some that pain and other symptoms of the patient, they will remain undiagnosed with the sonography. So we therefore fully agree with the Kessel statement to state that an X-ray is best used to check a hypothesis which has been formed by the history of the clinical examination. So it means that the clinical examination and the history, that is very important, and that will decide that the X-rays that to check which modality. So the X-ray is best used to check a hypothesis which has been formed by the history and the clinical examination, and that's why a comprehensive and thorough clinical examination should be conducted. The plan radiography, the this is next. This is the first we will discuss in the technical investigation, and the main indication of the plan radiography are the X-ray. They are they are being prescribed the radiographs when the therapist want to evaluate some fracture or some dislocation at the shoulder area. When the therapist want to have some imaging of the bony disorders such as the tumors of the shoulder area, shoulder structures, the humeral head or the acromion, or to image some metastasis. The plan radiography, they can also be used when the therapist want to identify the calcification in or around the tendons of the different muscles, and when the indication is when there is need of evaluation of the interior and posterior instability. Although the ultrasonography is nowadays the most frequently used method to evaluate the rotator cuff lesion, plain X-ray, the plain radiography examination can be of use in the detection of the accompanying appearance, such as the changes in the correct acromion arch, an unusual form or a spur of the acromion. So radiography is also still educated in the long-standing massive cuff tears. Ultrasound scanning, we are talking this that diagnostic ultrasound, not therapeutic ultrasound. Ultrasound scanning is mainly educated for the detection of the of the partial rotator cuff lesion, detection of the full and the partial rotator cuff lesion. An experienced hand, it can reveal not only the integrity of the rotator cuff but also the thickness of its various component tendons. Therefore, some careful positioning and thorough knowledge of the dynamic anatomy of the cuff, the experienced ultrasonographer can image selectively of these muscles. But the experienced ultrasonographer, the person, the technician, the doctor, the therapist, which is using the ultrasound for the detection of these elements, for having the image of these, he or she would use the careful positioning and the dynamic anatomy, the knowledge of the dynamic anatomy of the cuff. After that, he can be able to have selectively the image of these muscles like the upper and the lower subscapularis, the bicep tendon, the interior and the posterior supraspinatus, the infraspinatus, the teres minor. The ultrasonography that has further advantages, and these are: it is not invasive and safe. The bilateral examination are quickly performed. The shoulders can be examined dynamically, and above all, the procedure is inexpensive. There is no X-rays, so there is no risk of the X-rays exposure. One important disadvantage of the ultrasonography is that the results are examiner dependent, and a good outcome can only be expected in the experienced hands. Specificity and sensitivity are as high as 98% and 91% respectively, in comparison with the surgical finding which were claimed by the Mack et al. Specificity and sensitivity are the two terms which can be used, or the two parameters which are used to classify a test, that either it is a good test, it is a bad test, it is accurate, or it is not accurate. So specificity and sensitivity, they are very high for the that for this ultrasonography, that is 98% and 91%. Some other studies that have also found an overall sensitivity of the 97% in diagnosis of full cup tears and 91% of the important focal thickness tears. Along with beside the specificity and sensitivity of these ultrasonography, there are any other tests. The positive predictive value and the negative predictive value can also be used to check the accuracy or to check that preciseness of the different tests. If we define the specificity, that is to the rate of the true positive rate. The true negative rate, while sensitivity is to find out the true positive rate. It means sensitivity means and all the population which are being tested, how many population they have test positive for that condition. So it will just measure the true positive rate, while the specificity that is the rate of the true negative. It means all the population, how many people have been tested as negative when actually they don't have the disease. So the specificity, they measure the true negative rate, and the sensitivity, that measure the true positive rate. While we have discussed the other two parameters, which is the positive predictive value and the negative predictive value, so we can say that the positive predictive value is the total positive, the true positive, and when it divided on the all positive, either if it is the true positive or it is the false positive. So that rate of the true positive among all positive, either the false or true, is known as the positive predictive value, and the negative predictive value is the true negative, when the rate of true negative among all negative reports, either if it is the true negative or if it is the false negative, then that rate of the true negative will be known as the negative predictive value. So the specificity and sensitivity, they both are expressed in percentage, and higher the percentage, higher will be the accuracy of that test. Now here we can see that the specificity is 98%. So it means that in 98% of the people, this test 98%, 100% when healthy people, this ultrasonography will identify and will give 98% true negative rate, that 98% have no disease or no such rotator cuff or other disorder. The sensitivity is 91%. It means if all the people they are with the disorder, so this ultrasonography will give true results in 91% of all the population. So regarding when checking these videos, we can say that this ultrasonography is one of the best, one of the accurate and precise technical investigation which can be used for the different disorders of the shoulder joint. Other researchers, they have found overall sensitivity of 97% in the diagnosis of full cup tears and 91% in partial thickness tear. It means this ultrasonography, they will is best for checking for the detecting the full cup tears, but its sensitivity then reduce. It will give more false reports when there is partial thickness tears, but that intensity and that magnitude of the false report, that will be very less when there is full cup tears. The arthrography, single contrast arthrography, can be helpful in the diagnosis of a number of the problems, a number of disorders, including the complete tears of the rotator cuff, the incomplete deep surface tear and instability problems. It will show loss of the axillary fold space and diminished joint capacity in adhesive capsulitis. But because this disorder is so easy to detect clinically, the arthrography should never be required. It is of no assistance in the clarifying the differential diagnosis in cases of the impingement in the absence of the rotator cuff tear. The arthroscopy, the third and the next, the fourth technical investigation is the arthroscopy. The scope is useful for both the diagnosis and treatment. It should be regarded as an adjunct in those cases where the normal diagnostic aids are insufficient, as it offers an excellent view of the glenoid labrum and capsule. It is an excellent technique in the repair of the shoulder instability. However, confronted with the almost perfect results obtained through the examination of this technique, the physician should never forget that full and partial tears of the rotator cuff exist in a substantial part of a normal asymptomatic population. The magnetic resonance imaging has rapidly become a commonly used technique for the shoulder evaluation, providing its utility in the evaluation of the muscle tendon, hyaline, and the fibrous cartilage, the joint capsule, the fat, the bursa, and the bone marrow. There are two types of the MR images. One is known as the T1 image, the other is the T2 image. You can simply memorize these two and understand these two images by this simple mnemonics that the T1 means that one tissue will be brighter, and that is the fat, while in the T2 image two tissues will be look brighter and will be look whiter, and this is the one is the first fat and the other is the water or the fluid. It means that in the T1 image only the fatty tissue there will be look brighter, but in the T2 image both the liquid or the fluid will be look brighter as well as the fat as well will be look brighter and whiter. It is the most accurate non-invasive method available for the imaging rotator cuff, and why it is the most accurate, as it gives us the detailed anatomy of the detailed location and situation of the soft tissue, so that can be used, and that's why it is very commonly used for the detection of the rotator cuff tears. The major advantages of this magnetic resonance imaging, it is non-invasive in nature, lack of ionizing radiation, so there is no risk of the X-ray exposure, excellent contrast and atomic resolution, multiplanar imaging capability, and ability as a single imaging modality to evaluate simultaneously for a wide variety of pathologic processes. One disadvantage is that the focus of soft tissue classification may be missed on the MRI. As with all techniques that provide optimal visualization, one should always take into account the high rate of the asymptomatic lesion and never rely simply on the outcome of the technique to make a diagnosis and start a treatment. The second last technical investigation, that is the computer tomography or the CT scan. The CT scan is equally as accurate as MRI for the evaluation of the glenoid rim and labrum, the humeral head and the glenohumeral capsule, but the disadvantage of the CT scan as compared with the MRI is that there is exposure of the X-rays, so that's why the CT scan, being as accurate as the MRI, that is less commonly used for the rotator cuff or the other structures as compared to the um, MRI imaging. MRI is to be preferred because it is more accurate in tendinopathies and no X-ray exposure occur, as we discussed. And shoulder instability, the CT arthrography seems to be the best diagnostic method. The last technical investigation which can be used during the clinical examination of the shoulder, this is the Bursoscopy. Bursoscopy can be performed under general or local anesthesia. There are almost no indication for the Bursoscopy. It may be a diagnostic lesion of the dorsal part of the rotator cuff. At the same time, it offers visualization of the acromial roof. So that was the end of the clinical examination of the shoulder joint. If you have any questions, so you can just contact me and you can just any type of question without any hesitation. So that was all about the clinical examination of the shoulder joint. Thank you so much.